Yeah, good afternoon to everyone. Sorry for having kept you waiting. We had some little technical difficulties in logging in. So welcome to all of you and welcome to Dr. Iftikhar, who is our consultant pediatric orthopedic surgeon. He's kindly agreed to present on the early management of DDH, which is developmental dysplasia of the hip. Yeah. So over to you, Dr. Iftikhar, without wasting any more time. Thank you.
Hi, good afternoon, everybody. My name is Dr. Iftikhar, and thank you very much, Doctor, introducing me to you guys. So today we are going to talk about early management of DDH, which is quite commonly heard and seen around the GPs and pediatricians. So let's move from here. 1 second, the slide is. Okay. So etiology of the DDH is actually basically developmental dysplasia means there is a shallow socket of the baby's hip joints and which can predisposes for slipping or subluxation of the hip joint. So it can be multifactorial, can be syndromes associated with it, or it could be even genetic, like arthrogrypotic children or Larsen syndrome. Intrauterine positioning of the babies also plays a major role in that. Of course, other neurological disorder like spina bifida is also important. Now, how often do you see these kind of children in your practice? Well, the etiology is like almost like 1 in 1,000. That means one dislocation of the hip you may see in 1,000 children, whereas dysplasia you will see 10 in 1,000. So it's much more you will come across in your practice. Now, it could be prenatal positioning, that is intrauterine crowding of the babies, which can present in such a way that it can cause or predisposes to dysplasia of the hip. There could be also other conditions like metatarsal adductus or torticollis, which may be one of those signs where you could actually keep in your mind while during your screening. Now, screening of all the neonate is very essential, and you guys, all the pediatrician and GP, they do very well in this line. So what do you look for these children when you do your screening? Well, most of the time you need to look at those 5F signs, like first baby, female child, feet first presentation, that is a bridge presentation, flexibility, that is hyperlaxity of this joints and the other joints, family history of DDH. These are the signs which are very important, or they are the risk factors which can actually let you think in that direction. So when these are risk factors, so if you have those risk factors, you can next thing do is to do ultrasound to proceed with the treatment management, or you can refer to the pediatric orthopedics from that point onward. Now, if you look at it, the anatomy of the newborn is extremely important in that if you look at it, there are a few factors which play a major role in the displacement and dysplasia. For example, you have the iliopsoas tendon, ligamentum teres, capsule, limbus. All these structures are hyperlax at the early days of the birth, which can be showing in a normal anatomy. These structures plays major role in the subluxation and so on. So as the child grows, these structures get also grow up, and then at infant stage, the same structures causes subluxation. The labrum become everted, and then there's attenuated ligamentum teres, which can lead to the same scenario. And if these are missed at early stages, one can end up having, in older infants, we can have dislocation. When there is a dislocation, again, there is an inverted labrum, hypertrophied ligament. So all the structures are getting occupying the capsule or the joint instead of the head of the femur. So we come across quite often a terminology like hip click. What is hip click? It's actually palpable and audible sensation about the infant's hip joint during physical examination. It is you cannot hear it, but you can have the sensation, especially the person who's doing the examination. Now, these terms or these hip clicks terminology used when there is no instability of the hip joint. That means Otolani and Barlow's tests are negative during the evaluation. Now, hip clip is most likely caused by either intra-articular synovial folds like ligamentum teres or extra-articular structures such as iliotibial band, which moves around the greater trochanter and lateral condyle of the femur. Now, does the hip click require a treatment? Well, generally disappears within 4 to 6 months of the age. But one has to follow up these children so that you establish that the examination remains negative for the instability. Now, there are certain findings clinically you can see in the children. For example, you will see there is normally a good abduction of the bilateral hips equally, symmetrically, but there's no contractures of the hips in younger children. Sometimes you will see both the legs are not the same. If you flex the knees 90 degrees and hip 90 degrees, and you look at the height of one of the knees is lower than the other, which suggests there is a dislocation or subluxation of the hips there. Now, there is asymmetrical skin folds, especially in the proximal thighs, can be also significant. Now, Galeazzi's sign is what I just explained to you, that hip flexion to 90-degree, adduction, and knees do not line up in the same level. Now, when you come to further asymmetrical skin folds, those skin folds, which I just mentioned earlier, they are not just anteriorly like this one here, but they are actually going right at the back, going around the medial thigh and all the way to the buttocks. So these are the skin folds which are asymmetrical. They're not bilateral, or sometimes can be bilateral. But in this situation, when they are going all the way back to back of the thigh, that signifies that this hip is shortened, or this hip is dislocated or subluxated. Galeazzi sign, as I showed you here, one of the leg is shorter than the other. Ideally, it should be the same level. Now, here is the range of motion of the hip. Hip abduction should be symmetrically, both sides should be able to abduct the hips symmetrically. But here you see one side is restricted. That suggests the hip is not in place. Now, sometimes you have bilateral hip dislocation when there is hyperlordosis. That is usually presenting a bit later stage, and the waddling gait when the child already started to walk. It's usually later after that 6 months. Now, one must continue the screening where you do the Ortolani and Barlow's maneuvers with a thorough history and physical examination, head-to-toe examination to detect any associated conditions. Sometimes you will see a child with torticollis, ligamental flexity. All these are basic things one have to look into. Baseline neuro and spinal exam would help in diagnosis. What is Ortolani maneuver or hip instability testing? Well, it is Ortolani means you are trying to dislocate you're trying to reduce the hip from dislocation. So what you do is, this test you do, hips are examined at one at a time, flex the hip and knees to 90 degrees and abduct, gently abduct. When you bring to abduction, so the positive test means femoral head reduces into the acetabulum, and you will hear a clunk sound, or you felt basically audible clunk that suggests that hip is relocated. So that means hip was out and now you reduced it. So this shows that there is instability. Positive mean yes, it can go in and go out. What is the next test? Barlow's test. Okay, Barlow's maneuver again is for the hip instability. So you flex and adduct the hip. Now here you're trying to dislocate the hip and see if dislocation is possible. So if there is unstable hip, then you will flex, adduct the hips by bringing the thighs towards the midline, and then while applying light pressure on the knee and direct the forces posteriorly. So the positive test means what? Positive test means femoral head will dislocate posteriorly from the acetabulum. Now, dislocation is palpable as head slips out of the acetabulum. Okay, so Ortolani will confirm your diagnosis because you can reduce the hip and then again dislocate the hip. So that means hip is unstable. It comes out and in and out at your will. Now, when you have a risk group, further should be screened. They should go further evaluation. That means you need to do ultrasound if your exams, clinical examination is inconclusive. Of course, and if 5F signs are positive and your Tolani positive, Barlow's positive, that means you need to refer this patient to the pediatric orthopedics. In spite of doing all those screenings, sometimes still you'll find some cases they were missed or they were not treated at early age and they end up having more serious problems. Like, for example, here's a child which was missed. He has bilaterally hips are dislocated and they're going way above the hip joint. But the child, when walks to you, it can mislead you because he's walking normally. He's having waddling gait, but his hyperlordotic spine, you can see it can tells you that there's a dislocation of the hip there. This is a classical way to diagnose them when there's bilateral dislocation. Now, how do we investigate these children? Well, ultrasound is what is first thing you should do. Usually, I see a lot of children are referred with the X-ray at the age of 1 month. Usually, in these children, the bones are all cartilaginous. So, X-ray will not show the cartilaginous part of it. Mainly, it will show the places where there is ossification. So I think up to 3 months or even 2.5 months, it's okay. One can do ultrasound to confirm the hip is in or out and whatever, or dysplasia is there. And then after 2.5 months or 3 months, do an X-ray. That's where you will see the ossification centers and you will see a lot of bony part of the pelvis and hip joint. Although the femoral head ossification occurs in 4 to 7 months, we can always go for arthrogram and CT at a later date, but not in the early stage. Now, what is the role of ultrasound evaluation for this hip dysplasias? Well, it is very important that you diagnose early and catch the disease early, and you can treat them with better results, better outcomes at very early stage. The good part of this ultrasound is that you can do it even while on public harness. Public harness is the one picture on the lower side. You can see it's like a special brace which comes and you apply on the child. You can apply from the day one within first week basically. The success of harness is maintaining the reduction can be determined by serial evaluation during the first week of itself of the public harness. Now there are some angles, alpha angles, which we need to follow during the ultrasound, which I'll come to later. Now, near conclusion of the treatment, the final stability in reduction can be done with dynamic ultrasound test. Now, of course, the ultrasound is operator dependent. It's useful to confirm that there is subluxation. And of course, there is cartilaginous dysplasia of the acetabulum can be identified by ultrasound at that stage. So when you do ultrasound, baby is usually lying down and very relaxed and or sleeping. So you do ultrasound in such a way, you will see these images there. Now, here I've shown you ultrasound picture, plus I've shown you diagrammatically explaining where is the abductors and where is the femoral head. So this is the femoral neck. This is how you see the ultrasound. And this is the abductors on the side. and you have an ilium there. So if you draw here, this is Graph's alpha angle or Graph's classification to identify the ultrasound-based dislocation or subluxation. Normal angle is the red line on the inner side of the pelvis is the alpha angle. So it's 60 degree, more than 60 degree is a normal angle. If it's between 43 and 59, it is subluxation of the hip is there. And then there's less than 43 means the hip is dislocated already. The line usually bisects the head of the femur in 50-50. That means the hip is right in the center. But if it starts to go 60-40 or 70-30, that means the hip is slipping out of it. Just to give you an idea only. So now, what do we do for x-rays? Well, if you look at the x-ray, femoral head appears in 4 to 7 months. But if you see before that, at age of 3 months, you have to know few lines to understand those x-rays, to read the x-ray as pediatrician or as a GP person. So there are Shenton line, Perkins line, Hallen-Reiner's line, and then you have central edge angles there you need to look, acetabular index, and the teardrop. Now, teardrop in the x-ray, you will see this sometime in DDH, this may be the only sign in mild subluxation. Now, here's the x-ray, for example. The yellow line here drawn is the Hallen-Reiner's line. Then we have the 2 green lines that comes from the anterior inferior iliac spine. That is your Perkins line. And then we come to other lines in a way. So here is the Shenton line. If you can see the one with somewhere there, these are the red ones are the Shenton lines. This red one here, horizontal line, is the Hallen-Reiner's line. Now, this is the X-ray, let's say. This P means Perkins line. So you draw 2 lines from the top, you drop them, and then you have a 1 horizontal line. This divides each hip into 4 quadrants, A, B, C, and D. Now, A is the ideally where the femoral head should lie. If it goes to C, that means it is subluxating, but it's not dislocating. The moment the ossification center goes above this horizontal line or Hallen-Reiner's line, it means it's dislocation. For example, here are the 2 heads. Both are inner lower quadrant. That suggests the hip is perfectly fine. It's not dislocated, it's not subluxated. Now, if you go, and this is the Shenton's line, the green line, that means it goes from the neck of the femur to the inferior pole of the superior pubic rami. Now, here, this is how you check the acetabular index. So now this is the X-ray here I'm showing you again. This hips looks abnormal if you look generally after drawing those lines. So I draw the lines here, Perkins lines and Hallen-Reiner's line, 4 quadrant, and look where the heads are. They are not in inner lower quadrant. So this is obviously it is dislocated hip. It is very high riding and subluxated. Okay, this is how you can tell the difference between 2. And look at the Shenton line. If you draw, it's broken. It's not continuation of the C type. C. So these are the few lines you can tell by looking at just plain X-ray and tell dislocation and where it is lying. Now, this is Pavlik harness. We always talk about Pavlik harness brace very early you need to apply. This is very good in treatment of early DDH. It is a flexion, abduction, orthosis. It consists of multiple straps, chest straps, anterior flexion straps, posterior abduction straps. Now, device is designed to maintain 90 to 100 degrees of flexion and limited adduction. Now, because the device is not rigid, that means child's own musculature aids in maintaining the hip in reduced position. Remember, this device is not intended to hold the hips in force, flexion, and abduction, but instead it is designed to allow for motion of the hip within the range of reduced hip. Now, it is very important to know, okay, the brace comes as ready-made, like as shown in the picture, But it is you, physician, has to know what to do with the brace. It's not coming ready-made as kind of universal. You need to adjust each part of the brace. So it's a responsibility of the physician because sometimes can error occur. Like if you straps around the cuff are too tight, that means there is excessive knee flexion. If posterior straps are too tight, which means excessive abduction. So there is tighten anterior straps to provide 110-degree of flexion. Again, there is insufficient flexion. So all those things matters and the error occurs so that the result or outcome is not exactly what you expected. Now, when you apply this public harness, you should have already done the screening. You check all those 5F signs, and you did the Otolani and Barlow's test. So if fully reducible hip, then this will help this public harness. Other thing is the family has to be very cooperative. If the family does not keep the brace on all the time, the results will not be as good as you expect. Therefore, close regular follow-up every 4 weeks. We follow them every four weekly and we adjust the straps because the baby is growing. You can't keep what you put in 1 month and after 4 months it'll be same. That means you're done the wrong thing. So you need to every month you need to adjust those straps and make sure you do X-ray to make sure the hip is contained. Now, how long do we keep this public harness? Usually 6 to 7 months. Or you can say the hip stability when you achieve the hip stability plus 3 months. But around 6 months to 7 months max. After 7 months, this brace has no function. So how does the failure occurs? Well, parents sometimes don't apply them properly. Sometimes the physician is not good. He did not apply properly. And sometimes the physician he does not recognize the persistent dislocation. So he just keeps on changing because I've seen the picture, I've seen the video, I'll just keep on applying. But you forgot that there's a hip is still outside. So you need to keep on checking those hips and those lines. Now, what are the complications? Yes, of course, there is complication with the brace, avascular necrosis. That means when you force hip abduction, it will go into AVN. So there is a safe zone for the abduction, adduction, and flexion extension. So that zone is very important to keep in mind. Femoral nerve palsy can occur when there is hyperflexed hip for longer time. Now, sometimes we treat them immediately, treatment of the hip, ultrasound done in 2 weeks in the harness. You apply the harness right from the beginning, from first week itself, and then you do ultrasound 2 weekly, and then 6 weekly, and then visit weekly. Now, sometime we've been thought at the very early stages that diaper will help. Well, triple diaper technique prevents hip adduction, but there is no successful treatment as such. You can use the diapers in case the patient is in NICU, premature baby. You cannot put the brace on them, so you want to make sure at the same time hip is not adducted or dislocated. So you just apply the diaper temporarily for the purpose of in ICU or premature baby, but it's not success. It's not a treatment. It's not a management. Now, what is the success of this polyhydroxy? It's just a brace. It's not doing anything. But actually, when you look at the results, you will see, well, it does a lot of unbelievable things. Now, here, if there is public harness success rate, dysplasia, if the child has dysplasia, 95% of the dysplasia will get corrected by this public harness. Now, in dislocation, if the hip is dislocated, 30% of the hip dislocation will reduce within 24 hours. So 30% will reduce within 24 hours. 85% of the reduction within 1 week. So you will know the result within 1 week, let's say 2 weeks. The hip should be reduced. If it's not reduced, there's a problem. That means either the straps are not put properly, either things are not going right way. So we have to look for that and reevaluate it. Now, to summarize this thing, let me tell you from the top there. So if you see abnormal hip at birth, you look for it. Is it subluxated or is it subluxated or dislocatable? If it's only subluxated but not dislocated, you observe for 3 weeks and reevaluate. And after reevaluation, see again, is it subluxating still or is it stable? If you feel after 3 weeks the hip is stable, then you can discard the treatment and just follow up on a regular basis. But if you feel that after 3 weeks of observation, it is still subluxation, then start public harness. Public harness will either stabilize the hip or it will still be subluxating. If it is stabilized and you check if there is any dysplasia, if no dysplasia, then wean off the harness over a period of time. But if it's still, in spite of public harness, subluxation is there, that means you have to go and reevaluate whether there is any neuromuscular disorder associated with it. Now, if you come on the top again, the hip abnormal at birth, is it dislocated or dislocatable? Now, if it is non-reducible, then neuromuscular disorder, and that means you need to go and operate. Now, if it's reducible hip, public harness, and then public harness will tell you if it's reduced in 2 weeks, then continue the public harness. Now, if it is not reducible, you reevaluate it, and then probably by the time you reach 6 months, you need to have a closed reduction or open reduction of the hip joint. Now, many GPs, sometimes even other doctors I see, they come up after 4 months to my clinic, and they've been on treatment with diapers alone because their GP has told them, just put 2 diapers, it will work, a child will grow out of it and perfect. Well, the concept is fine. You're trying to keep the abduction, preventing the adduction, but it does not help. It is ineffective of double diaper treatment, or it's not the treatment. You can temporarily do that. It's ineffective. Use of double, triple diaper is actually inappropriate. And basically, you'll be just wasting your time doing nothing. So one has to discourage this practice of diapers for DDH. Now, if the hip is reduced and suppose it's not reducing, you have to do closed reduction and put hip spica. This is something called, this kind of cast is called hip spica. It is just that hip is kept in fixed position in reduced way under imaging and under anesthesia. And that stays for 6 weeks, and we remove this cast and make a different cast after another 6 weeks. And then usually he comes out of it very quickly, and child goes back to normal activities. And that's basically it. Thank you. If you have questions, you can ask, or
Thank you so very much, Dr. Iftikhar. If anybody has any questions, you can unmute and ask. So, Dr. Iftikhar, can we just go through this? I know this is a very informative lecture, especially for us pediatricians, because we encounter newborns day in and day out, and considering that the incidence, the prevalence is so high, very, very important for us to pick it up early and refer timely. So if you could just give us some homegoing message, thank you.
Yeah, thank you. Well, 5Fs are basically very daily. You will see them, but sometimes you will miss them. Let me just come to that point here. So basically, you will see this child every time. You will see them, but only thing is you're not able to really pinpoint those points. It's, for example, if you ask them thorough history, they will tell you, yes, in my family there is another child who had similarly DDH and been treated. So that should alert you to, okay, so let's look into furthermore. So hyperflexity syndrome, like you need to make sure that hips are not hyperlaxed. Feet first, that means we call it breech. Of course, all the breaches, you have to rule out that this is one of the risk factors. And female and the firstborn. And sometimes it is more common left side, of course, in females. So these are the 5 Fs. If you can just go along with your, the Ortolani's and Barlow's test, I think you'll be fine. You will find a lot of more cases and a lot of load for us, basically. But I think it's very easy to catch those. The problem is if you catch early, even if you are not sure, you can still refer because you will say, well, I think it's a female, it's a firstborn. That's why I want to refer to you, which is perfectly fine. Absolutely nobody, because you're helping this child from avoiding or missing that one baby. Maybe you looked at those 2 points, say, well, all 5s are not there, 5Fs. So maybe I will not refer. It may be a little bit embarrassment. No, it's in fact, if you see those folds, the medial thigh folds, as in this picture there, you immediately look for that there's a big possibility, and we have to rule out DDH. Because if you save this child's future by protecting them and by looking for these signs, you will be doing a great job. Basically, it's a screening program, and you will never miss anything. You can miss hip clicks and all that. Those things are different. But here, these folds and those signs are very, very, very difficult things that you should miss. You should not miss all those things, basically. And then you can, of course, do the Kiliazi sign by flexing both the hips and look at if they are at the same level. The knee, it takes no time. Or if you do range of motion of the hips when you flex, or you abduct and adduct, you will see there is restriction. Both sides is not the same. So if it's not the same, again, you have to rule out those things. I hope that answers some of your doubts, I guess.
Thank you, Dr. Iftikhar, for this nice presentation. I'm Dr. Muhammad Farani from Manama branch.
Thank you.
Doctor, so from your presentation, so hip click by itself is not significant in case of a child who's not having the 5Fs, the child on examination is having some stability of the hips in the neonatal period. So hip click by itself doesn't mean the child is having DDH, right?
Correct. So the hip clicks will actually kind of wake you up, and it's a warning sign and say, wait a minute, there's a hip click. Let me just look into other things, which you actually maybe sometime you missed them, or you were like maybe your examination did not conclude. So you say hip click is here. Okay, that also give me alarm. I must rule out. Is it really the hip click? Sometimes can be a sound of Ortolani and the Barlow's tests also, because you did movement and actually hip went in and out and then caused that pain. The click sound. But that is also noticeable by the parents, because families say, I was just changing the pamper, and then suddenly I hear this sound, or I felt in my hand that clunk there. So that kind of alert the doctor, said, okay, wait a minute, let me rule out. So it's not necessarily means that it is a CDH, but it can be an alarming sign for you to rule out. Once you immediately do an X-ray and you did Ortolani Barlow's, it's no more clunks there, then it is cause of the click is from the iliotibial tract, which is moving over the greater trochanter, or sometimes from the lateral condyle of the femur, which can cause similarly, because the iliotibial band actually snaps over this bony prominence. But it should alarm basically to you.
Thank you. Thank you so much.
Thank you.
Thank you, Dr. Iftikhar. This is Dr. Sana, also a pediatrician at Manama. Just had a quick question. For all our breech deliveries, whether male or females, we do do an ultrasound, but we do it at 4 to 6 weeks. Do you recommend that as well? At 4 to 6 weeks of age is when we do it?
Well, as a screening, maybe you have a different protocol. But for me, if any of those other signs are there, suggesting that ultrasound is done, for what purpose you will do 4 to 6 weeks? Is it because you have some kind of a doubt about hip dysplasia, or as a routine, you mean?
We do it as a routine for all breech deliveries. We do it as a routine for all breech, 4 to 6 weeks, whether male or female.
Yeah. Yeah, so I think that's good that in breech you do this ultrasound to rule out dysplasia and or subluxation of the hip. Now, during these 6 weeks before that, at the birth, maybe you will do those screening examination of the hip joint. Will suggest also whether if any other issues are there associated with breech presentation. So, but you can do 6 weeks is perfectly fine. But let's say if this child breech presentation already have dysplasia and the hip is kind of subluxating at 3 weeks, and but you're still waiting for ultrasound at 6 weeks as routine, so you miss this 3 weeks of hip dislocation or subluxation. So for me, I would examine the first time and first week, for example, and I feel there is a little bit doubt because you present breech presentation. So I would do one 2 weeks just to make sure that I'm not missing any part of the treatment. Because at 2 weeks, if I catch and treat them, it's much more better than at 6 weeks or 8 weeks. That's a bit on a late time. So at 2 weeks, if I catch this dysplasia, I will immediately apply the treatment, Pavlik harness, and or whatever way you want to treat, and then that goes on from there. So I know I did not miss it. But at 6 weeks, there may be dislocation of the hip already from birth, and because it was a breech presentation, and then you missed it, and then you are waiting for routine. Then the blame comes there, why it was not done earlier, why it was not caught earlier when you could treat them at the very beginning. So in my opinion, I think 2 weeks should be where ultrasound should be done.
Sure. So this is when we have breech plus examination findings, which are suggestive. I'm just trying to put it into our daily practice, because usually we see newborns after birth, maybe 2 or 3 days later. And then the next routine visit for regular newborns would be at 1 month of age. So would you still say that's too late? And we call our breech deliveries maybe at 2 weeks of age as well for a routine check?
Yeah, I think, I mean, you see, everywhere else, the practice is different because they examine right at the time of birth itself, the first examination. And then from there, they know roughly where they're going. And if they have any doubt at that time itself, then they would call back after 2 weeks. But for me, as a pediatric orthopedic, for me, I think it should be treatment should be started immediately. For example, if another condition like with a breech, with CDH or DDH, we get also the club feet. So when we see from the birth time that there's a feet are clubbed or club feet are there, we will not wait till next appointment after 6 weeks, because the club foot treatment start on the day 1. Basically, the today's baby is born, maybe after a day or two, I will put the cast on them, because the feet becomes rigid with days. Every day the things get rigidity gets more and more. So if hip dysplasia is outside, you can quickly reduce it within 2 weeks or 3 weeks. That's wonderful. But if you will come back at 6 weeks, it will come back, but then by that time, the tissues are start growing. The baby is growing bigger and bigger. So in my opinion, I think 2 weeks ultrasound will not harm anybody, not the baby, not the doctor, and not the parents.
Sure. Thank you, Dr. Iftikhar.
So would you recommend that the routine screening ultrasound is predated from the current 4 to 6 weeks to 2 weeks? And is this the best time to pick up hip displacement in any
Yeah,
baby?
the thing is, that in those children which are having high risk factors, those like breech, female, hyperlaxity or syndromic child, yes, I would say you do it early, because some of these children, not all, but the high risk children, which syndromics, they are very difficult to treat at later date. For them, the day they come out, you need to do something to prevent the contractures. They start developing contractures. They start getting like all the structures start to get tightened up. So it's a bit difficult to treat them at 6 weeks or 8 weeks, because the structures already start to get those contractures developed. So it's better to treat them early. So those risk one, but not the routine normal children screening programs. Those are, you can tell, all those factors are not there. So those children which are having none of those factors, no need for them ultrasound at that stage. But those children which are prone for these kind of risks, yes, they should do it early, so treatment can be started early.
Doctor, from your experience, the DDH incidence in Bahrain, is it like high, or like how frequent do you encounter it in your practice?
Well, Bahrain as such, the incidence is very, very low. But there are people who are not from Bahrain. For example, I've seen a lot of Syrians, a lot of Yemenis. Those countries, they have, and those families which they have like kind of inter relation marriages and all that, they do have them. And a big number of my series of CDH of surgeries and the list, uh, majority of them are from these countries. But very few from Bahrain as such, Bahrainis.
Thank you for your valuable time, Doctor.
Thank you.
Doctor, I have one more question. So when you detect a click in a baby at birth, what is the optimal time to get an ultrasound? That is number one. I mean, we discussed that at 2 weeks, but then as started, in case you detect the big click and has all the other factors, risk factors, do you wait for 2 weeks or do you get an ultrasound given that? That is the first question. The second is, in the interim period, supposing you have already an ultrasound in 2 weeks, is this that factor going to help in any way or it doesn't matter? Just about the
Yeah, thank you. So those are good questions. You see, what was the first one? Click. Okay. So suppose I examine today this child and there's hip click there, and those signs are there, the risk factors are there. I will not wait for 2 weeks. I will today itself. The patient came to me, so I will send it for ultrasound, and I will rule out, because I don't want this patient to come to me and then maybe after 2 weeks he may not be able to come for whatever reason. Then they postpone, and then you see you missed this opportunity. The day you diagnose that there's a hip click, I want to rule out. I want to get satisfy the patient that yes, there is nothing there. This click is only from your other than the joint. So that rules out for me immediately. I don't wait for another 2 weeks. I will do it today itself. If not today, maybe tomorrow. But within that acceptable time schedule. Now, in regards to what was your next? Double diaper. Yes. See, the double diaper really does not do anything, because the diapers are only kind of very soft. And what happened to the worst part of it is, I wanted to show you the other picture. The thing is, let's say, if same picture here, what is shown there, let's say instead of this white swab there, I put a diaper there. Let's say I put 2 diapers. Now, most of the people, even until today, they swab the babies, right? they will wrap their legs from this side, and the pamper is in the middle there. So what happened is actually there is some obstacle in the middle of the thighs, and then you are trying to tighten the legs together from the ankles. So you are actually forcing the hips to go out. You know, the hips are, because pampers in between act as a kind of spacer, and then you bring the knees and legs, feet together to tighten them, swaddle them, so the hips goes out. So that makes it worse. So if you want to put pampers, let's say 2 or 3 pampers temporarily, because yeah, don't swaddle, don't wrap those things. If you want to wrap, okay, wrap just loosely, very loosely, so keeping in mind that you have pampers in the middle, and when you try to bring the two feet together or ankles together, you are actually forcing the hips to go out. And if they are already kind of at the edge, like a borderline or subluxation, then they will remain that subluxated or even become dislocated during your this time period. So the Pampers does not help at all to begin with for the treatment. Like I said earlier, you can use those Pampers for time being, temporarily, for a short time, not as a treatment, but only to get until you get the treatment. So if the baby is in ICU, and baby is very, very premature, small, I cannot put the harness on the baby. All right, now I'm going to put the Pampers because baby is not moving much. The legs are apart. They are not close to each other. So there you put a Pamper to keep the abduction, so that hip will, whatever you do movement, the hip remains close to the hip joint. The moment baby is growing, that doesn't work. So it's only a temporary one until you get the public harness, and then that should be good. I hope that answers the question. Thank you. Thank you so much.
So, I think the takeaways from this should prompt us to change our practice, especially the screening time, and prompt more prompt reference to the outcomes. Thank you so very much.
Thank you. Thank you.